So now go to another case. Okay, there is a 33-year-old lady with severe constipation and cold intolerance and menorrhagia. So you must be thinking, what are the symptoms? It is not so easy. So constipation, cold intolerance, and menorrhagia means it is a what? It is hypothyroidism symptom. And you can see TSH is 127 is very high, and FT4 is undetectable. So patient is having FT4. If you remember the 9 square table, FT4 is undetectable, and TSH is 124 means it is primary hypothyroidism. What is the treatment? We have to replace with levothyroxines. So coming to the basics, you must have read in MBBS. So there are various causes of primary hypothyroidism. Among them, most common is Hashimoto-thyroiditis, iatrogenic, when followed by subtotal or total thyroidectomy. And you should not forget various drugs like iodine, lithium, interferon alpha. These are also causing hypothyroidism, and iodine deficiency is the most common cause in our part of the world. Transient hypothyroidism is caused by soft-acute hypothyroidism, and the causes listed here. And secondary hypothyroidism also you should not forget, because sometimes the patient present with TSH is high and T3 or T4 is also high, then you have to think of secondary hypothyroidism. Or TSH is low or T3, T4 is low, you have to think of secondary hypothyroidism, because they can have pituitary adenoma on MRI. So you have to think of that. So an isolated TSH deficiency or inactivity, these are all the conditions. They can have hypothalamic tumors, trauma, all leading to secondary hypothyroidism. Okay, so you have to always be inquisitive and follow the 9 square table. So symptoms, all the common symptoms signs you all are aware of. Weight gain, cold intolerance, but less common symptoms also you should be aware of. So what are the less common symptoms? They can have only muscle cramps or muscle stiffness. Okay, they can present with only depression or irritability. They can present with hoarseness of voice or anemia only, or rare symptoms like they can present with psychosis. In mixed edema coma, the patient will present in the emergency with full psychosis, and sometimes we have seen referral from the surgery or gynae department for galactorrhea. The patient is complaining of something white coming out from her milk breast, a milk-like thing, unmarried woman. So this is galactorrhea, impotence. Then you have to think of patient might be having primary hypothyroidism. They can present with cerebral ataxia. So these are the rare, but you have to think. If you don't rule out other causes of such condition, it might be hypothyroidism. So this is the classical photo of the hypothyroid lady. You can see depressed lady with a puffy face, moon face, okay, and eyes. So if you see what you do in the patient with primary hypothyroidism or suspected hypothyroidism is, if the TSH is less than 20 and the features of secondary hypothyroidism not there, and the patient have a features of transient thyroiditis, like patient might be having subacute thyroiditis, like they can have neck pain, and they can have less than 12 months of postpartum stage, they have recent symptoms of thyrotoxicosis, or less than 6 months of undergone thyroid ablation or thyroidectomy. This all can cause iatrogenic hypothyroidism. So we have to replace the patient with levothyroxine for 4 months only in such patients. And if normal, after 4 months or 6 months, then you can stop. Another scenario can be patient might be in drugs. The psychiatric patient might be lithium or amiodarone. So what you do in such patient, you have to treat. Or the patient might be having repeat acute illness has resolved, and patient might have undergone thyroid ablation and hypothyroidism is there. You have to treat with the T4. The patient has anti-TP antibody positive. This is isomethylthyroiditis. You have to treat. If the patient have goiter with primary hypothyroidism, you have to treat. But there is a question: how do you treat? What is the dose of levothyroxine? So if somebody of 50 kg comes to your patient or hypothyroidism comes to your OPD, you have to start with 1.6 to 1.7 microgram per kg body weight. So if it is 50 kg, you start with around 75 microgram per kg body weight if the patient is young, active, without any complication. But if it is elderly patient with cardiac diseases, you have to start with the half dose. If it comes around to 75, you start with 37.5 microgram per day. What is the more important thing in patient with hypothyroidism? We all will be not telling the patient is, tell the patient to take the thyroxine tablet on empty stomach. That everybody can tell. But another important thing is they should not take anything after taking that tablet for half an hour to 1 hour. They should be fully empty stomach. Because why? There are certain drugs or certain food that will interfere with the thyroid tablet absorption. Okay, if the patient is having iron tablet, calcium tablet, they have to take the thyroxine tablet only after taking that 3 to 4 hours of taking that tablet. These things you have to tell to the patient specifically. And if the patient forgot to take the tablet in the morning, what you do? You tell the patient to take the tablet in the evening, but after 3 to 4 hours after taking the food, if they forgot. Okay, this is very important. Everyone will be missing, forgot to tell this in the OPD because of busy schedule, but this is very important. So what, after starting the patient with thyroxine, when should we order the TFT? Basically, usually we order after 6 weeks of the treatment. And what is the target TSS level? That is very important. We start and we don't know what is the target level. So the target level of TSS should be 0.5 to 2.5. Unless and until patient 0.5 to 2.5 target level is not achieved, we have to increase the dose of thyroxine 12.5 to 25 microgram per kg body weight per day. And if the patient TSS fall 0.5 below 0.5, then we have to decrease the dose. Okay, this is very important, TSS target level. So what is the improvement? After starting the thyroxine, don't tell patient you will be like a normal patient immediately. So the patient will feel better after 2 to 3 weeks of treatment only. Okay, and the first improvement in the sign of patient with hypothyroidism is the reduction in weight. If they are 100 kg, don't tell the patient you will be 50 kg directly. The weight gain in the hypothyroid patient is due to the accumulation of glycosamine glycan fluid on the subcutaneous tissue. So there will be decrease in weight of around only 3 or 4 kg. Okay, not drastic 10 kg. Okay, and after weight reduction, they can have a decrease in facial puffiness, skin changes, and like that. Now coming to the another important disorder of thyroid, that is thyrotoxicosis. There is a 55-year-old lady comes with a thyrotoxicosis to your OPD. T4 is 19, very high. KS is 0.001, is very suppressed. There is no doubt this is a thyrotoxicosis. So whenever the patient of thyrotoxicosis comes to your OPD, always send for a nuclear scan, always, if there is a facility available. If no, then not needed. You can treat with the TFT level. So you can see in this is a nuclear scan done, and you can see there is uptake of the scan in the right thyroid gland, but less, both the thyroid gland, right more than left. No. So what is the diagnosis? In this lady with the raised T4 and suppressed TSS, the nuclear scan shows the diffuse toxic goiter, which is suggestive of grave disease. So this is the how you can diagnose a patient with thyrotoxicosis. So you all are aware what is thyrotoxicosis. There is a elevated T3, T4 and suppressed TSS. So what is the commonest cause of thyrotoxicosis? Is Graves' disease. There are causes like thyrotoxicosis without hypothyroidism. So excessive intake of levothyroxine tablet, there is factitious thyrotoxicosis you have to rule out, and thyroiditis, because thyroiditis patient will classically resembles of thyrotoxicosis. But how to differentiate with thyroiditis and with thyrotoxicosis? The thyroiditis patient will have neck pain, they will have a goiter, they will have fever, and raised ESR. But the thyrotoxicosis patient does not have that. They have a symptoms and suggest of thyrotoxicosis like palpitation, weight loss, like that. We have done a study of clinical spectrum outcome of patients with hypothyroidism in DPKHS. We have found that most common symptoms of hypothyroidism are palpitation in our patients, and majority of patients improve with anti-thyroidox within 6 weeks of treatment. So like hypothyroidism, the common clinical features of thyrotoxicosis you all are aware of, like weight loss, palpitation, heat intolerance, everyone will tell, palm edema. So you should be aware of less common. So less common symptoms of thyrotoxicosis is osteoporosis. They can have anxiety, psychosis. They can have loss of libido, impotence. They can have atrial fibrillation. Any patient with atrial fibrillation, you have to do thyroid function test. If the patient on proximal myopathy, we have seen patient on proximal myopathy having hypothyroidism. So we have to rule out that. And the rare possibilities. If there is exacerbation asthma also, you have to do TFT. If there is a gynecomastia in the male, basically, you have to do TFT. Hypothyroidism can cause gynecomastia. Sometimes if the patient present with a hyperthyrotoxic periodic paralysis, they will have weakness of all four limb, quadriparesis, four limb, upper limb and lower limb. Okay, in such cases, they can have thyrotoxic periodic paralysis. So how to go ahead with the patient with thyrotoxicosis? So whenever there is a patient of thyrotoxicity and clinically they are thyrotoxic, we have to see the features of Graves' disease present or not. So what are the features of Graves' disease? It's very easy to remember. Remember eye and neck. The patient having goiter or not, and with the brew, and the patient is having proptosis, ophthalmopathy or not, and the patient is having nail changes, and patient is having edema of the leg or not. If all these three things are present and clinically they are thyrotoxicosis, this is 90% Graves' disease. For confirmation, what you do, you send for TSH receptor antibody. It's not necessary, it's very expensive test, but if you are in doubt, you can send that. And this TSH receptor antibody is positive, and the patients have undergone less than 6 months of recent pregnancy, they have a neck pain or flu-like symptoms, they are on drugs like amiodarone, they are palpable multinuclear goiter or solitary nodule, you have to send for scan, nuclear scan always. If there is a facility available, no available, then we can start with TFT report and symptoms, you can start with the treatment. You can see that there is a various category of the nuclear scan picture in this slide. So if the patient have low uptake of thyrotoxin, you have to think of transient thyroiditis or extrathyroidal typhoid source. If the patient have only solitary black shadow hair, only one uptake, that is toxic adenoma. If the patient have multiple diffuse uptake, this is a toxic multinodal goiter. If the patient has uniform diffuse uptake of both the gland, then this is the diffuse toxic goiter of Graves' disease. So what are the abnormalities in the lab with the hyperthyroidism besides depressed TSH and elevated T4 and T3? They can have raised ALT, AST, they can have raised gamma glutamate transferase level and alkaline phosphatase. Okay, they can have increased bilirubin, mild hypercalcemia, and glycosuria acidosis mellitus also. Graves' disease, I won't be in details, you all know that. Pathology also, you all know that. But what should you remembering this from this graph is, the Graves' disease patient can be euthyroid after 2 years, or they will be a hypothyroid lifelong. This is very important to remember. So whenever the patient of hypothyroidism Graves' disease present, you treat with the medications, anti-thyroid medication for only 2 years. After that, there is no use of that medication. You have to refer the patient for radioiodine therapy or thyroidectomy. So these are the, you can see the beautiful pictures here: proptosis, goiter, clubbing in the thyroid patient, that is thyrotoxic patient, that is thyroid acropathy and periobital myxedema. So what are the anti-thyroid drugs you start in the patient with Graves' disease? You all are aware of that. We can start with carbimazole or propylthiouracil. But if the patient is having breastfeeding or patient is pregnant, you cannot give carbimazole. You have to give propylthiouracil. So what is the important thing while giving carbimazole? You tell to the patient is hypersensitive reactions. These drugs can cause hypersensitive reaction. If the patient develop fever, rash, with taking this drug, tell the patient to stop the drugs and come immediately. And they can also cause granulocytosis and hepatotoxicity. Propylthiouracil can cause ANCA-like vasculitis also. Okay. Another treatment which I have told is total thyroidectomy. If you do the total thyroidectomy, what happens is patient can have a paralysis of recurrent lateral nerve and they can have a loss of voice. That's why. So what are the indications of subtotal thyroidectomy? If there is a large goiter, the patient is not improving the drug treatment, or they are very poor to drug adherence, the patient has recurrent thyrotoxics, a course of anti-thyroid drug in young patients. But what is the contraindication of thyroid? If they have undergone private thyroid surgery and they are a singer or lecturer, then you should not do, because they might lose their voice of paralysis of left recurrent lateral nerve. So what are the disadvantages of this subtotal thyroidectomy? They can have hypothyroidism 25%, Along with the thyroid gland, parathyroid gland might be removed, so they can have transient hypocalcemia, or they can have hypoparathyroidism and recurrent larinopalsy. Another important treatment for hypothyroidism, radioiodine, is mostly followed in Western countries. The indications is patient more than 40 years of age, recurrent following surgery, irrespective of age, and other serious comorbidity. But you should not give this radioiodine ablation therapy if the patient is having pregnancy or planned pregnancy within 6 months of treatment and active Graves' ophthalmopathy. It is contraindicated. And in the young children also, you don't do radioiodine active therapy. What is the side effect? It's like since you are ablating the thyroid gland, shrinking the thyroid gland with radioiodine, it will cause hypothyroidism. 40% patient in first year, 80% after 15 years. So, what is the dose of starting carbimazole? So, you usually start with 5 to 10 milligram per day for TDS or OD or BD, or you can start with the methimazole equivalent dose, OD dose. Maximum dose of carbimazole is 40 to 60 milligram per day. Or propylthyroxine is we start with 50 milligram BD. The maximum tolerated dose is 400 to 1600 milligram per day, and this drug is given after food. There is no doubt. Usually, the patient of thyrotoxicosis become subjectively improved. They will think, they tell their palpitation has decreased, they have become now cool after 10 to 40 days of treatment. They are not anxious, and biochemically they become euthyroid after 6 to 8 weeks of treatment, most of the patient. But some patients require 12 to 18 months of therapy for the remission. So between 15 to 70% of patients with Graves' disease will subsequently relapse, usually 2 years of stopping the treatment. Because I already told you cannot give the drugs after 2 years. You have to stop, so they cannot relapse. Either they have to refer for subtotal thyroidectomy or radioiodine. So what are the risk factors for relapse of thyrotoxic patients? These are the risk factors. Is more common in younger age, male sex, presence of goiter is there. If the patient has high titers of TRAB antibodies by both diagnosis and cessation of anti-thyroid therapy. Rarely T4 and TSH levels fluctuate between those of thyrotoxicosis and hypothyroidism at successive review appointments, despite good drug adherence, probably due to rapidly changing concentration of TRAB. So these are the certain issues. So in these patients, satisfactory control can be achieved by, there is a regime called block and replace regime. That means you are blocking something else and replacing something else. That means you are blocking the thyroid hormone synthesis in patients with thyrotoxicosis with carbimazole. Okay, you are giving high dose of carbimazole, 30 to 40, 60 mg. And since you are giving carbimazole anti-thyroid drugs, it will causes hypothyroidism, no? So you have to replace the thyroxine. So this is known as block and replace regime. Okay, understood? So you give carbimazole 30 to 40 milligram and add levothyroxine to replace the normalize the thyroid function test level 100 to 150 microgram of thyroxine. This is known as block and replace regime. But you should not give this medication for long. It is given only for 6 months. Traditionally, subtotal thyroid is performed in which a portion of one of lobe thyroid is left, which I have already told, and another is because they can have a hypothyroidism, so we have to lift that. In the most centers for radioiodine active therapy, 10 to 15 micromilli of radiation is given, and this regime is effective in 75% of patients within 4 to 12 weeks. So you have to, what is treatment of Graves' ophthalmopathy, or important things we have to do counseling in the patient of thyrotoxicosis. They have to maintain the euthyroidism. They have to stop smoking because smoking can aggravate Graves' ophthalmopathy. So smoking should be stopped. And avoidance of bright light on dust because they can have since they are in proptosis, they can have a keratitis. So you have to avoid the bright light and dust. Sleeping with the headrest because they are having swelling of the eyes. No, so this is basically the treatment of Graves' ophthalmopathy. Use of artificial tears, use of simple eye ointment at night, diabetic therapies to decrease the swelling of the eyes, steroids to decrease the swelling of the eyes and anti-inflammatory effects, and surgical decompression of the orbits. The Graves' ophthalmopathy treatment. So another important issue in the management of thyroid disorder is We see lots of pregnant lady referred by gynae department with hypothyroidism or hypothyroidism. So I found in OPD most of them are over treating the patient of thyrotoxicosis with pregnancy. That's why I am first discussing thyrotoxicosis with the pregnancy. There is a 29-year-old pregnant lady performed thyroid function test in first trimester. Her T4 is 1.3 nanogram per deciliter and total T4 is 14 microgram per deciliter. TS is 0.2. There is no symptoms and signs of thyrotoxicosis. So is this thyrotoxicosis? There is a slight suppression of TSH in this patient. There is a raised T4 level. F4 is normal. So you must be thinking this patient might be having subclinical hyperthyroidism or a thyrotoxicosis, and you might be starting carbimazole. But it is a wrong approach. Why? The reason is during the first trimester of pregnancy, what happens? There is SCG, no? So SCG has a similar homology of TSH. So SCG thyrotoxicosis can cause suppressed level of TSH. So you should not treat the patient in the first trimester of pregnancy with thyrotoxicosis if they have a suppressed TSH. That might be due to SCG level. So you have to wait and watch for 3 months and repeat the TFT after 3 months. Okay, don't give carbimazole. So what is the target level of TSH in normal pregnant patient? Normally normal patient will keep a TSH level which we have discussed before is 0.4 to 4.2. But in case of pregnancy, in the first trimester the normal level of TSH should be 0.1 to 2.5, second trimester 0.2 to 3, and third trimester should be 0.3 to 3. So what are the things you have to discuss when in patient with pregnancy and thyroid disorders? What is the indication of thyroid function test in pregnant women? We have to know what is the preferred TFT in pregnancy, which I have already told, when to do the test, differentials we have already told, and frequency of TFT to be carried out in the pregnancy. So these are the indications. Whenever the patient have past history of thyroid dysfunction, family history of thyroid dysfunction with pregnancy, patient of goiter in pregnant patient, when they have anti-TP antibody positive, then type 1 diabetes, history of suffered infertility, previous bad obstetric history, and hyperemesis gravidarum, you have to treat. And in the patient with pregnancy, along with TFT, you also do anti-TP antibody if you are suspecting subclinical hypothyroidism or primary hypothyroidism. And if you are suspecting Graves' disease, you can do TSH receptor antibody. And if the pregnant patient have a goiter nodule, you have to do ultrasound. So I have already told, no, so you should not over-treat the patient with Graves' disease in pregnancy. So they can have a alpha SCG mediated hypothyroidism because alpha subunit SCG stimulate TSH may present a transient thyrotoxicosis, hyperemesis, or trophoblastic hypothyroidism. So they are usually less severe and occur transiently in the first half of gestation, and the treatment is symptomatic. The patient might be having vomiting, give fluids, and supportive treatment. Okay. But if the patient you have a doubt, you can send for a TSH receptor antibody in such patient. And if it is positive, then it is a Graves' disease in pregnancy. In such patient, in the first trimester, you give propylthiouracil because carbimazole causes the aplastic cutis of the children or the baby. And second and third trimester, you can give carbimazole against start. So in thyroid disease in pregnancy, trimester specific ranges I have already discussed. Iodine deficiency, there we have to replace with the iodine. If hypothyroidism, replace with thyroxine. But in pregnancy, the dose is increased. We have to increase the dose of TSH if the patient is taking 50 microgram before pregnancy. After pregnant, we have to increase from 30 to 50%. You can make it 75 or 100 because you already know in first trimester we are keeping the level of TSH as 0.1 to 2.5, second trimester 0.2 to 3, and third trimester 0.3 to 3. That is the level. So because if you do not keep this level, the patient can have, mother and child both can have a problem. Mother can have preeclampsia, baby can have low mental or low IQ they can have. So this is a very important complication. Okay, thyrotoxicosis we have already discussed. What about postpartum thyroiditis? Means the patient, you have treated the patient of hypothyroidism and thyrotoxicosis first time in pregnancy, and after the pregnancy what you will do? So after the pregnancy, sometimes they can develop thyroiditis. So it is not recommended to screen all the pregnant women with the TFT in the postpartum thyroiditis. But TFT can be recommended to be done after 4 to 6 weeks of the postpartum period. Okay, or the patient having type 1 diabetes or having positive anti-thyroid pertechnetate antibodies. Now coming to another, after hypo and hypothyroidism and thyroid disorder in pregnancy, another common symptom or disease that present patient OPD is the thyroid swelling. Okay, so the thyroid swelling can be thyroid nodule or they can be malignancy of the thyroid gland. So how to approach patient with the thyroid nodules? So 9.6% of adults have a goiter of the thyroid nodule, or 5% of adults have nodules. And data shows that 4 to 6% of men and 5.6% of women have discrete nodules or thyroid nodules. 9 out of 100% have a thyroid swelling or nodule, which is very common, and 1 in 1 lakh person may have a thyroid cancer among that nodules. So basically, how to approach? I won't be telling details. So this slide, if you remember, is very easy. So if the patient of thyroid nodule, we are always sent for thyroid function test. If the TSS is high or normal TSS, we send for FNEC or USC guided biopsy of thyroid nodule. And if the FNEC non-diagnosed, repeat FNEC. If the TSS is low, and you have to send for nuclear scan. If it's a hot nodule, you do the radio ablation surgery or anti-thyroid drugs because hot nodule is normal. If it's a cold nodule, you should suspect malignancy, so you do by FNEC. So if there is a cyst, you do surgery or follow-up. If there is a benign, also you do T4 suppression. If with the high TSS, if it's suspicious of follicular carcinoma, you have to do surgery. If it is malignancy, basically papillary carcinoma, you have to do surgery. And papillary carcinoma has a good prognosis as compared to the follicular carcinoma. So with this, I would like to end my talk here only. Thank you very much. I hope you people must have some basic knowledge of how to approach a patient with thyroid disorder. Any doubt, you can call me or mail me or post me in the Facebook. Thank you very much.